All right, so in the title, we could not figure out what to teach you guys or what to tell you all today. So I said, well, can you hear me? Am I loud? Okay. So what I thought was I'll just go ahead and talk about what is happening in the cath labs. I mean, as you guys go through your surgical residencies and anesthesia, these are the things I need you to all to know for the next year. So first, there are top 5 things. So the first, number one thing you all ought to know, again, these are things happening in the cath lab. These are patients who are you guys are going to see at a later stage or maybe because somebody crashed. So first is coronary angiography, IVUS, OCT, FFR, IFR. This is what we do in the cath lab to assess coronary artery disease. So if you look at coronary angiogram, the obvious things are obvious. LAD, RCA, circ. I'm not going to get into all those things. What is the number one limitation? What's the number one limitation? Any guess? Coronary angiogram completely underestimates plaque burden. How much narrowing does it have to be before stenosis happens on an angiogram? 40%. And that happens because of positive remodeling. Human arteries are designed to accommodate blood flow, so it keeps on expanding. So you almost sometimes have to have 40% plaque buildup before luminal narrowing happens. And remember, what we are doing is luminogram. And that's why there are these issues with overestimation, underestimation, so on and so forth. The second challenge also poses is surgical targets for you all, because like this is an example of an RCA, and I had sent this patient for bypass surgery. Well, as it turns out, the lima was done to the LAD, there was a vein graft to OM. However, they could not graft that RCA because I was so surprised when I heard that there was nothing, nothing surgically revascularizable. However, this entire RCA was diffusely diseased, severely calcified. So coronary angiogram doesn't tell you the whole story. So there are ways we have tried to learn a little bit more about coronary arteries. Is it working?
Yes, sir. It's moving.
Okay. So the first thing we have started doing, for example, in that coronary artery, we ran this IVUS. And in IVUS, we can actually see what seemingly looks like again, the photographs are not great, but what seemingly looks like a healthy section of the artery is severely atherosclerotic with a lot of calcification. The hyperechoic shadows are the calcium, and this is all atherosclerosis. So you can all see that with an IVUS, which normally on an angiogram you can't. OCT is another new technology you guys will keep on hearing about, and that is one of the highest resolutions. We use that a lot after we have deployed a stent, and we are worried about restenosis, we are worried about dissections and disruptions of those plaque. In this one, this is the OCT catheter. That's our wire, and the wire creates a little bias. But what you may be able to see are those stent struts. So this artery already has had a stent. Now what is happening inside the stent? You have all this intimal hyperplasia. So this is all re-narrowing. Even though it looks really nice and good, this is all at least 50% restenosis in this artery. And that's the benefit of doing OCT. But probably the biggest advancement in the cath lab in the last 3-4 years is FFR or IFR. So remember, whenever we are doing angiogram, whenever we're looking at lesions, we are looking at them in a resting manner. We see an intermediate stenosis, 50-70%. We don't truly know whether it is stenotic or not. And that actually becomes very relevant for the surgeons too. Because I would have sent patients to Dr. Rule and we would say, well, is that LAD significant or not? We recently had a case like that. Now sometimes if you were to do an FFR, you can assess the hemodynamic significance of that intermediate lesion. FFR is almost done like a stress test is done. You know how you guys have patients go through stress tests? Have you heard of Lexiscan or regadenosine stress test? So what Lexiscan or regadenosine does, it causes hyperemia. All the coronary beds become hyperemic. It kind of almost creates a stress like metabolism of the heart. And when we do that, we can actually see any differences in diastolic coronary blood flow. And based upon that, studies have validated certain numbers. So for example, this is an example of an RCA where an FFR was done for this lesion, and after adenosine injection from resting to hyperemic state, you can actually see a separation, and it comes to 0.85. Then there is another LED lesion here where something similar was done, and the FFR comes to 0.68. Now, you can argue, well, is this bad? Is it 50%? Is it 60%? If I were to probably ask 10 cardiologists, someone would say 50%, someone would say 70%. But remember, you have to talk about dropping in lemas and things like that, so very relevant information. So we are doing more and more of FFR. As you can see in this particular artery, the FFR is 0.68. So just for simplicity purposes, remember 0.80. That's your cutoff. If you ever get reports saying FFR is less than 0.8, that lesion is deemed hemodynamically significant. Please put in a bypass graft. Okay? There is also another new technology called IFR. IFR is where we don't have to inject adenosine. IFR is where we don't have to inject adenosine, but we get a catheter-based diastolic pressure waveform differentiation. And in that one, the number is 0.89. IFR is a relatively new tool. You're not going to see that much yet. Very few labs around the country have it. But what you're going to see a lot is FFR. Actually, there are insurance companies which actually ask interventional cardiologists to say, will you do an FFR if the lesion is deemed intermediate? So it's become very common part of our practice. In your generation, you guys are going to see a lot of FFR reports. The second thing I want you to know. So first thing was CAD and imaging. The second thing I want you to know are stents. I think it's relevant for your field to what's happening in the cath lab. We'll talk about where the stent has evolved, bare metal stent to DES, first, second generation. There's something called biodegradable polymer, bioabsorbable, and talk a little bit about depth therapy. So things have evolved a lot. Remember, we have been doing angioplasties since the 70s and 80s, and in the 90s, we were doing mostly bare metal stents. So from POBA, bare metal stent allowed us to keep the artery open. We would have less quote-unquote emergencies of perforations and dissections. However, we had a massive issue with restenosis. In 2003, by the time we got to drug-eluting stents, restenosis reduced. So what is the current state? And this slide only takes you to about 2006, but this has only gotten better. So for example, PCI failure, where we can't do it. I mean, it used to be 40%, and now it's barely 2%. In our cath lab, PCI failures are probably 1 to 2%. Emergency bypass surgery, again, because of better equipment, obviously the biggest advantage is a stent, which creates a permanent scaffold, has gone down significantly to 0.5%. Restenosis, this is probably the biggest important advancement in interventional cardiology, and thanks to drug-eluting stent technology, it has gone all the way from 40%. I mean, 40% is where we would put in a stent and hope it would not restenose. Now it's down to 10% or even 7%. In today's world, if some company wants to introduce a new stent, and if the restenosis rates are more than 8%, nobody's going to use it. So 92% of the patients at 1 year don't have restenosis. And that is one of the reasons why cath lab volumes are down, because there was a time when I was a fellow, every third patient we were dealing was restenosis. But we don't see that anymore. Stent thrombosis, because of advances again in stent design, but also the antiplatelet therapy has significantly reduced to about 0.5%. And very late stent thrombosis, which is kind of a new thing we have identified in the last decade or so, has been steadily declining also. This usually means after the first year. So what are the stents you guys got to be aware of? What are the names? So this is what Cypher was kind of the first drug-eluting stent. It was approved in 2003. Texas came out in 2005. Endeavor was there for a brief time. But these are the current, the ones in the green are the what you guys are going to hear about. I want to point out some subtle changes or advances in the stent designs and technology. This is what has allowed our field, interventional cardiology field, to advance, is this very slide. For example, we have moved away from stainless steel. So if somebody presents to your data on a stainless steel stent, you have to almost kind of think twice about it now, because we have found much better alloys, cobalt nickel, platinum chromium, cobalt chromium. Strut thickness has almost halved from 140 to 150 microns. Now anything more than 80 microns is kind of scoffed at. Polymer is nothing but a plastic we apply on top of the stent to give the drug molecules, and that, as you can see, also has become thinner. The drug choices have moved from paclitaxel and sirolimus to what I call everolimus and zotarolimus, something which has the best healing power. We actually now believe that drug elution or the drug is only required for 3 to 4 months. Anything beyond that is unnecessary. Anything shorter than that could be harmful. Now, beyond this, there are 2 other stents which are approved in USA, which you will probably encounter in your clinical practice. The first is a stent called Synergy. In the Synergy stent, it's kind of very unique. We sat down with the biomedical engineers and said, well, I mean, yeah, we are happy with the drug-eluting stents, the Zions and Promus you've given us, but let's make something better. So A, we wanted to make thinner strut. The second thing we wanted to do was put the drug only on the arterial wall side, because any drug where the blood flow is inside the artery is kind of wasted. Not only that, wherever you have to put drug, you have to put this polymer. And as I said, polymer to us is nothing but a plastic. Like you buy an iPhone, you put that little shield. That's what polymer is. It cracks, it webs, and so on and so forth. So it causes chronic inflammation. So to get away from that, we kind of say, well, hold on. Do we really need to put polymer on the blood flow, the luminal side? Because that is where the endothelialization is happening. And if you are cracking that polymer, the cell is not going to form very well. So we try to create this abluminal polymer. But then there is also this thought about, gee, this polymer, we require the drug for 3 to 4 months. Why keep that polymer there forever? Maybe we can come up with a biodegradable polymer. So now we have this polymer on the abluminal side, which biodegrades at 3 months. So the polymer is gone. This becomes a very thin strut bare metal stent. The drug elution has already happened. As I said, it's only for 3 to 4 months. And after 3 to 4 months, all you have left in this particular artery wall is a 78 micron stent. So this is kind of one of the newest advances in the stent technology. The second thing which is approved in US, which is kind of the first itinerations, in a way also done first generation in US, is the Absorb. You guys may have heard of that. There's been a lot of news. Absorb is a completely bioabsorbable scaffold. It is made out of PLLA, polyl lactic acid. So once in the body, it actually dissolves through the Krebs cycle. It takes about 2 years for it to completely dissolve right now, maybe even 3 years. The strut thickness, as with the first generation, is very thick. So remember I talked about how thin the struts have gotten? Well, this is still at 150 microns. We have some markers at the end because we can't really see this on angiogram. So if you guys ever see an angiogram with an absorbed stent and has been sent for surgery, you won't be able to see the scaffold, even if it is just implanted 2 days ago. All you'll see are platinum markers right here at the end. It's basically just a plastic, PLLA. It uses everolimus drug, and again, it kind of dissolves completely at 2 to 3 years. The reason this has not become, in a way, has not had too much of market penetration is because we are seeing high stent thrombosis. So normally, as I said, stent thrombosis of 0.5% is all that is allowed, all said and done. Well, in the data, in this particular trial, showed 1.5%, so much, much higher, very high rather, than we would be comfortable with. But I think this is possibly one of the things in future, in 10 years, by the time you guys are practicing out there, you'll see many more patients getting absorbed because there are so many, almost 12 or 14 varieties of these devices happening right now in Europe. There are a couple of them coming into US in trials in the next few months. A quick note on DAPT therapy, because few things have changed. In June 2016, we kind of rewrote some of our guidelines. So normally all you may have heard is, gee, DAPT is required for at least 1 year. That is old news. The only time DAPT is required for 12 months if it is the stent is done in the setting of an ACS. ACS means MI, STEMI, non-STEMI, somebody comes to the ER with unstable angina. Those are ACS. Then it doesn't matter what type of, even a bare metal stent, because there you are treating the disease pathology. You're not really treating the stent, you're treating the disease pathology, because studies have shown that patients who are present with ACS have a very high reinfarction rate within the first year. To prevent that, we recommend DAPT for 12 months, irrespective of the type of stent. However, if the DES, drug-eluting stent, is done in non-ACS setting, somebody gets a stress test in their office and we do a cath and put in a stent, then the DAPT is only required for 6 months. Okay? And these are all relevant because not only you guys will be doing surgery, cardiac surgery, we're also vascular surgery. And a lot of our patients have cardiac and vascular problems. So a lot of those patients will have to sometimes wait for 6 months in the ideal world if you believe in that. In patients who are going for surgery, we recommend Plavix or Brilinta to be stopped 5 days in advance and FEN for 7 days prior to surgery. Our surgeons will tell you there are ways institutions work around this, there are platelet assays you can do, and so on and so forth. But this is the general guidelines. All right, number 3 fact I need you all to know. Left main stents. It's a hot topic. I'm just going to quickly go through some of those because you'll probably learn a lot more about this. So Syntex was a landmark trial. Syntex basically looked multivessel coronary artery disease. Some of them also had left main, and we kind of started looking at that. And PCI was inferior to CABG for the composite primary endpoint of death, MI, stroke, or unplanned revascularization. So as you can see, death, MI, and stroke, but especially what drives the most is the revascularization, which is much, much higher in PCI arm. But we kind of started digging deeper. That's what cardiologists do. So we started, well, let's try to divide the anatomy. I mean, not every multivessel disease is the same, because sometimes we come across 3.5, 3 lesions, and we say, well, this stent should really do well. So when we divided those patients into terciles, we gave them Syntex scores. And if you guys do not know this, please make sure you know Syntex score. Very vital for surgeons as well as cardiologists. So when we started dividing into 3 tertiles, we saw that the lowest score, the one with the least complex anatomy, so to speak, the differences were not as pronounced compared to somebody with very, very complex anatomy, which was kind of intuitive or expected. But the other thing we kind of started questioning ourselves is that we use taxus in this particular trial. So it's really not relevant today. I mean, nobody uses taxus anymore. We have very high event rates. And as I just wanted to show this slide because we kind of have this very important differentiation of events with the Xion stent, which is what we use nowadays, versus taxus of a significant delta. So we do much, much better than taxus. So then we said, well, let's create a study design which uses the current generation stent, and that was called Excel. So Excel was again unprotected left main disease. Without going into too much details, half of those patients, about 1,000, went to PCI, half of them went to CABG. And the primary endpoint of death, stroke, and MI at 3 years, not at 1 year, but 3 years, as you can see, is no different. In conclusion of Excel, we would say that treatment of patients with left main coronary artery disease and low or intermediate Syntex score, kind of less than 32, with the Xion's particular stent, result in similar rates of primary endpoint of death, stroke, MI at 3 years, with fewer adverse events within the 30 days compared to CABG. And those adverse events, infections and atrial fibrillation and so on and so forth, the rehospitalizations. What that has allowed us to do is offer left main to certain patients, stents. But it should not be practice, it should not be standard of care. However, we believe that PCI may be considered as an acceptable or even a preferred revascularization modality for selected patients with left main coronary artery disease. A decision which should be made after the heart team discussion, and we make sure in our institution we do that regularly, taking into account each patient's individual circumstances and preferences. The fourth thing I would like you to know about is coronary CTO PCI. CTO is becoming more and more relevant nowadays. When we do a cath, almost 20% of our patients have coronary CTO in some artery. And that's one of the commonest reasons for us to send them for bypass surgery. Again, I'm making you guys aware of this particular data is because it's becoming more relevant, something which we are doing much more commonly. Because even when we send them for bypass surgeries, for varieties of reasons, whether it's too disease downstream or just the conduit is not really good, almost 1/3 of them actually don't get bypassed. And that often is the main reason we are sending those patients to bypass surgery. We'll see an LAD 70% and RCS CTO. So that being said and done, a lot of things have happened in the last 5 years. CTO interventions have advanced a lot, and this is, apart from the new wires we have, the crossing catheters we have, we also have these techniques of what is called dissection reentry. So we basically push a wire through the plaque and then get into subintimal space, and there's a catheter called Stingray which allows us to re-enter distally here. And then we actually create a stent in the subintimal space. The second thing, well, this is an example of this is a vein graft going to an LAD. This was a 60-some-year-old patient of mine who has already gone through 2 open heart surgeries. This was a degenerative LAD vein graft which already has 2-3 stent procedures. And as you can see, the vein graft fills the distal LAD. From the second catheter, you can see the proximal LAD, and it kind of is completely occluded there. So what we did was we brought this Stingray balloon, which has a side hole, which allows me to come beyond the occlusion and then kind of re-enter, as you will see the wire progressing forward from the side of this actual balloon. And when we do that, this is that example of that re-entry. This allows us to put in a stent after this. There are also retrograde techniques, so now we can go from LAD to RCA, vice versa. We use septals. We can also use epicardial, but the commonest approach is usually septal because it's very safe for us. CTO interventions are increasing from a success from about 40 to 50% in the 80s or 90s. Now we are up to 80%. Our institution is about 85 to 90%. So this is an evolving field with a lot of progress. The last fact I want you guys to know is CHIP. You will hear about this every time you go to our conferences. There will be a session on complex high-risk interventions. And the reason this title has been created is because we have gotten better at supporting our patients who require very complex interventions because of high-risk anatomy, very calcified disease, or they are in cardiogenic shock. And often that may be the last conduit, like every other bypass is gone, there's only one vein graft or some lima hanging there. And those patients, when we do a balloon or rotablation, they get very ischemic with transient LV dilatation, they drop their blood pressure. So to prevent all that, a hemodynamic support, we used to use balloon pumps. We kind of have fallen out of favor. Pretty much all our high-risk interventions, we would use an Impella-like system. So as of today, there are always options for our patients. If I send it to our surgeons, it's always CABG, but we can also say we can do it from the wrist. The patient remains confused, but bottom line is create a heart team wherever you guys go. Good luck. All right? Thank you.
Thank you very much, Dr. Shah. He's got to get downstairs.